Thank you. Welcome, everyone. My name is Dini Arsono. I work at the Center for Interdisciplinary Research on AIDS at Yale University. I am the coordinator for CIRA's international research programs. And I would like to welcome you all to today's CIRA Talk titled Developing a Chatbot to Promote HIV Testing and Prevention. Before we start, I'd like to just go through a couple of slides to introduce you to CIRA. If you're new to CIRA, I want to let you know that the presentation slides and recording will be available at CIRA website in the coming weeks. And I would invite you to visit CIRA website to get a lot of information related to our work, our services, research course, people, affiliated research projects, and other opportunities and information. And we have an e-bulletin, an electronic newsletter that you can sign up for when you go to cira.yale.edu. You can put your email address at the top right corner of the web page, and you will receive information on upcoming events and other opportunities by email. Just to give you a heads up of a list of events coming in the next few weeks, and I will post this into the chat. And our next CIRA Talk is the third event on the list, reducing HIV transmission among people who use drugs. And we will have a guest speaker from the Boston University School of Medicine, Dr. Jessica Taylor. And all of this, apart from the HIV implementation science to optimize research impact or history. So the fourth event will take place in person in Dallas, Texas. But the other four events will be held via Zoom. And if you are interested in attending, you are welcome to click the link in the chat shortly and register to attend. So today's CIRA Talk will begin with a research presentation and followed by a discussion and Q&A session. We'll provide the link to the flyer that includes presenters, discussion and moderator bio, and the presentation abstract into the chat shortly. And today's CIRA Talk will be moderated by Dr. Luke Davis. Dr. Davis is Associate Professor at the Yale School of Public Health and Yale School of Medicine. He is an epidemiologist and pulmonary critical care physician whose research employs implementation science to improve the diagnosis, treatment, and prevention of tuberculosis. At CIRA, Dr. Davis serves as a scientific advisor for our international research activities and programs. And with that, I would turn the floor to Dr. Davis. Thank you.
Thank you, Dini, and welcome to our audience members. I see a number of familiar faces, and we're great to also have a few new visitors. Today's talk is an exciting foray into thinking about how digital health can be used to improve HIV testing and prevention. And we're really fortunate to have two very expert speakers joining us. The first is Zhao Ni, who is an assistant professor in the Yale School of Nursing. And his research focuses on mobile technologies to prevent cardiovascular disease and HIV/AIDS. He's conducted international research at the interface of chronic disease and M-Health in the US, as well as China and Nepal. And his current projects are focused on developing artificial intelligence chatbots, which is a really interesting topic we'll learn more about today, to promote HIV testing and prevention in Malaysia and among populations at high risk of HIV transmission. He'll be joined by his collaborator and colleague, Dr. Jeff Wickersham, who will actually be speaking first, who's Assistant Professor of Medicine and HIV/AIDS in the Yale School of Medicine. Dr. Wickersham is focused on improving HIV treatment and prevention outcomes among sexual and gender minorities, including transgender women, gay men, and bisexual men. And Dr. Wickersham's research is focused on the development of biomedical and behavioral interventions, including peer patient navigation, implementation of pre-exposure prophylaxis, that is PrEP for HIV prevention, development of AI, that is artificial intelligence-based chatbot technologies to improve uptake of HIV testing, and adapting mHealth applications for transgender women to scale up HIV testing and linkage to PrEP services. And most of this work is being conducted in Southeast Asia, especially in Malaysia and Thailand. And we're also joined today, fortunately, by Dr. Marek Chawarski, who is our expert discussant. He's Associate Professor of Psychiatry and of Emergency Medicine here at the Yale School of Medicine. And his research focuses on developing and adapting and evaluating interventions that are practicable and effective in resource-constrained countries. He serves as principal investigator or co-investigator on a number of studies that use pharmacological or psychosocial and behavioral interventions for a range of substance abuse problems and HIV prevention activities. And he also works in Malaysia as well as other countries and makes use of clinical epidemiologic studies, implementation science, and mixed methods studies, including qualitative research and randomized control trials. So we're really also important to have his expertise as a member and consultant to several international organizations, including the United Nations Office on Drugs and Crime and the World Health Organization. So with that introduction, my pleasure to turn over the floor to Jeff Wickersham. Please go ahead, Jeff. And I'll just encourage everyone to add your questions to the chat. At the end, we'll have a little bit of a discussion.
Thank you, Luke, very much. And thank you to Dini and to Luke for inviting Zhao and I to share some of our current work on artificial intelligence and chatbot technologies as tools for HIV prevention. We're really happy to be here to share some of this work. As Luke mentioned, our talk titled Leveraging an Artificial Intelligence-Based Chatbot to Improve HIV Testing and PrEP Uptake among MSM, and particularly in Malaysia is where we're going to be situated today. So Zhao, next slide. So just to situate us globally, where we're, the work that we're going to share today, where it took place, it's in Malaysia, a country of about 32 million people in Southeast Asia. You can see here on the map, two areas, Peninsular or West Malaysia, just south of Thailand and north of Indonesia, and on the island of Borneo, a northern section there, East Malaysia, although most of the work today took place in West Malaysia. All right, next slide, Zhao. Just to contextualize a little bit about the HIV situation in Malaysia, so that sort of contextualize the work that we're sharing today. On the treatment front for people living with HIV, in 2016, Malaysia changed its national guidelines and policies around HIV treatment to initiate ART regardless of CD4 count following international guidelines before being CD4 based. And in 2019, estimates suggested around just over a third of all people with HIV in the country were on ART, but only 11.9% of all PWH were virally suppressed at a CD4 of less than 200. And if we look at those individuals who are on ART, 57% of all PWH who are on ART were virally suppressed at about a less than CD4 of 200, which maps on not too far off of what we see in other settings, both regionally and internationally. On the prevention front, HIV prevention front, Malaysia is certainly making strides in this area. PrEP at the current time is not covered under the national formulary. So individuals who are seeking pre-exposure prophylaxis will not find it covered under the national insurance scheme. So it is currently fee for service only. And it's initially started to expand in 2016 following a UNAIDS and WHO funded PrEP demonstration study called MyPrEP, and a short abbreviation for Malaysia. And we have seen a steady increase of people taking on daily oral PrEP. Estimates run the gamut, to be completely honest, on how many people at risk are on PrEP, but our estimates suggest that less than 10% of MSM who are PrEP indicated, and that's the important part there, are receiving PrEP. And what we do see among those who are on PrEP, we see a lot of starting and stopping of daily oral PrEP and an increased interest in on-demand PrEP or 211, which is becoming increasingly popular among at-risk MSM in Malaysia. So we'll jump to the next slide there, Zhao. So how to intervene on the challenges facing Malaysia when it comes to HIV prevention, particularly among MSM. And in a country where discrimination is certainly high against sexual and gender minorities, they might not be so comfortable going to traditional in-person venues like government clinics called Klinik Kesihatan in Malaysia, where they might encounter that discrimination or microaggressions that make a rather uncomfortable environment for talking about sensitive topics like sexual risk behaviors and HIV prevention. So technologies like chatbots, which we'll talk about here in a moment, are an innovative and cost-effective way of reaching at-risk vulnerable communities while both minimizing potential, say, social risks, while increasing access to and uptake of prevention tools like PrEP. So what is a chatbot? Let's start with that. I'm guessing most of you are familiar with chatbots. You might be bombarded by a chatbot when you log into your bank's website. You may encounter it on an airline booking website. When you're booking your travel accommodations, a chatbot might pop up at the bottom right of the screen and say, hey, I'm here to answer any questions. Let me know how I can help. And a chatbot is just that. It's a computer-based program that's designed to simulate human interaction, but is in fact a program operating in the background, but uses human language and even idiosyncrasies of human language to mimic and appear human. Chatbots are deployed in a number of different contexts, especially in health services. Mental health services is a very popular domain where you see chatbots being deployed. One of the more popular ones, which made it to the New York Times not too long ago, is called WOBot. It's W-O-E bot. And it's a app-based chatbot that can be downloaded from the Google Play or App Store. And it uses CBT as a strategy for behavior change, whether it's depression, anxiety, even eating disorders and other types of mental health needs. It's also been used in hospital settings for chronic disease support like cancer. Chatbots are deployed both in inpatient and outpatient settings, where inpatients can use chatbots to learn about their diagnosis, especially in settings where resources are limited for, say, clinicians or nurses or physicians. And there are two main types of chatbots out there. One is a rule-based chatbot, and this is a very prescriptive chatbot. It's one that has set and defined paths that it can go to and how it can respond to users' inputs. Rule-based chatbots are very, as suggested by the name, bound by explicit rules. So you can't veer too far off the beaten path when interacting with a rule-based chatbot. The alternative option is an artificial intelligence-based chatbot, which is the direction that most chatbots have been going for quite some time. A simple example would be on your smartphone device, Siri or Alexa. Maybe you have a home device where you can ask Alexa to turn on the lights, or you can ask Alexa, how's the weather today? Those are examples of audio-based chatbots that use artificial intelligence. And this short diagram at the bottom sort of illustrates how an AI, short for artificial intelligence-based chatbot, would work. So a user would make an input. The system would analyze the user's request, and using data that chatbot sits on, it will identify the intent of that user's command or request or question or statement. And it will then decide predictively, this is the most likely intent, and here's how I should reply. The most simple example is, hey Siri, how's the weather today? The system has been asked that question. Oops, 66 degrees. There it goes. Here. Early morning. Then partly cloudy skies starting tonight. Temperatures will be fairly consistent. Okay. So if you ask such a statement, it's been asked billions of times. So the intent is very clear because it has a database to pull that information from and understand a reply and be very accurate with that reply. So an AI chatbot is really only as powerful and useful as the data that it's pulling from. All right, Zhao, let's hit to the next slide. So when I think of artificial intelligence, I'm aging myself, but the first thing I think of is KIT from the 1980s television program Knight Rider, starring David Hasselhoff. And KIT was an artificially intelligent car that could follow the instructions and commands of David Hasselhoff, and it could drive itself, it could answer questions. But AI has come a really long way since the Hollywood representations of AI. And that's where we are now in terms of being able to leverage this new technology. It's not just art on the silver screen, it's an actual tangible technology that can be implemented and deployed. Okay, Zhao, next slide. So artificial intelligence is the main, a large domain, large area of research. And in brief, it refers to the simulation of human intelligence and processes that uses computer systems that have used machine learning. So artificial intelligence, within that area of work, you have machine learning. And just to define these constructs real quickly, machine learning refers to a branch of artificial intelligence and computer science, which focuses on the use of data algorithms to imitate the way that humans learn and to gradually improve accuracy of responses. Deep learning, which we're not going to get into today, is also a subset of machine learning in which multi-layered neural networks learn from a vast amount of data. Bottom line point being, AI is using machine learning to learn from users' inputs. And there are two main ways in which we can teach a chatbot what to do, how to talk to community members and users who ask for, say, where can I get an HIV test? Or how can I get PrEP? Or what is PrEP? We can do one thing called supervised learning, where individuals like me or Zhao go in and teach the chatbot, okay, when a user says, where can I get PrEP? This is where you should take that user to this sentence or to this statement or to this branch of our algorithm. Unsupervised learning, the alternative domain, which gets into artificial intelligence, is where the algorithm, the computer systems can in fact themselves learn from users' inputs and from previous data. So that previous data is really quite essential in order to do unsupervised learning. Zhao, next slide. All right, so the objective of our work today is to build an artificial intelligence-based chatbot to promote HIV testing and PrEP uptake and mental health services access among MSM who are at risk for HIV in Malaysia. I'm now going to pass it over to Zhao, who's going to talk about the work and our findings so far.
Thank you very much, Jeff, for the excellent presentation. Next, I'm going to introduce the Chatbot project in details. As Jeff mentioned, the overarching goal of this Chatbot project is to build an AI chatbot to promote HIV testing, PrEP uptake, and mental health service access among MSM in Malaysia. And the AI chatbot will eventually be designed to be able to deliver education on HIV testing and prevention, screen for depression, and help MSM order free HIV self-testing kits, locate the nearest HIV testing and PrEP clinics, and contact MSM and connect MSM to mental health counselors. An AI chatbot is a mobile health intervention. Mobile health, known as mHealth, is defined as the use of portable electronic devices with software applications to provide health care services and manage patient information. Studies in MSM in the US, China, South Africa, and Peru find mHealth interventions as acceptable and significantly increase HIV testing by helping MSM overcome barriers through providing them real-time information, motivation, and behavioral skills. Despite benefits from these early mHealth strategies, they have not yet been scaled up yet because their design requires high intensity and sustained human inputs. For example, they often requires researchers to regularly and manually send personalized reminders, provide real-time guidance, and initiate referrals. To bring population-level effects, we believe that the next generation of mHealth intervention needs to be automating personalized messages, modifying them based on responses, and providing new outputs in real time. This project is a 5-year project, including 2 phases. The first phase is a 2-year exploratory phase, and the second phase is a 3-year R33 phase. In the first phase, and we will create this chatbot through 3 steps. In step 1, our team conducted focus group interviews to identify an online platform preferred by MSM for embedding the AI chatbot. We need to identify an MSM preferred platform because different population interact with social media or online platforms differently. Identify an MSM preferred platform in Malaysia can help us improve the generalizability of the AI chatbot. After the step 1, we developed and pilot tested the AI chatbot with the assistance of software developers and engineers. So far, we have completed the first 2 steps. We developed a prototype of the chatbot and conducted alpha and beta testing of the chatbot prototype. Recently, we are preparing for a national observational study to test the chatbot prototype and gather feedback for improving the chatbot. Next, I'm going to introduce the 3 steps with details. So far, we have conducted 5 structured focus group interviews. We recruited 31 MSM in Malaysia using web-based convening sampling and community outreach. An online screener was posted on MSM social networking apps, including Grandeur, Hornet, Blue, and etc., where MSM often meet virtually to find sexual partners. Inclusion criteria were cisgender male, 18 years old or older, condomless sex with another man in the past 6 months, and HIV negative or status unknown. All interviews were recorded, transcribed verbatim, coded using NVivo. We conducted a semantic analysis to inductively analyze the interview transcripts. Later, we emerged themes were mapped onto the 4 constructs of the unified theory of acceptance and use of technology. The 4 constructs, performance, expectancy, effort, expectancy, facilitating conditions, and social influence. UTAUT is an extension of the technology acceptance model that is commonly used to evaluate factors predicting people's acceptance of new technologies. We recruited 31 participants, consisted of 4 ethnic groups. The mean age of participants was about 30 years old. Over 22% of them had not tested for HIV in the past 6 months. And over 1/3 of them had a PHQ-2 score greater than 3, indicating the likelihood of depressive disorder. We found that most MSM had a positive attitude towards the use of AI chatbot for improving HIV testing and prevention. Multiple barriers and facilitators influencing MSM's acceptance of an AI chatbot were identified in this study. Performance expectancy, also known as the perceived usefulness of the chatbot, was influenced by MSM's concerns about information accuracy, the effectiveness of information dissemination, and the chatbot's ability to provide emotional support. Based on participants' previous experience with chatbots, they had a major concern that whether our AI chatbot could be able to provide emotional support. For example, one participant said that the previous chatbots he interacted with were too robotic and not human-like. The chatbot's effort expectancy, also known as the perceived ease of use, was influenced by the convenience, cost, and technical errors of our chatbot. MSM preferred Ai Chatbot as a convenient tool because it is fast, it can respond 24/7. One participant stated, in terms of convenience, I think it is brilliant because especially if you are planning to introduce it to the MSM community. Perceived technical breakdown could undermine MSM's acceptance of chatbot. Based on their previous experience with chatbots, they had concerns that sometimes the chatbot will encounter technical issues. Chatbot's ability to link users to healthcare professionals was facilitating condition of MSM's acceptance of Ai Chatbot. Last but not least, the social political climate in Malaysia, especially privacy issues and the stigma against and the criminalization of same-sex sexual behaviors are important factors for MSM's acceptance of any mobile technology addressing HIV in Malaysia. MSM consider Ai Chatbot as a useful tool for helping them avoid stigma and discrimination. Regarding features of the Ai Chatbot, participants like her user interface that is simple, concise, and easy to interact with. Most MSM preferred the Ai Chatbot to provide guiding questions and options related to HIV testing, prevention, and mental health care. Functions such as integrated text and voice-activated commands that facilitate rapid user-machine interactions were among the top features. Other preferences included optional notifications or reminders that can be delivered through text messaging or email, providing users with online to offline pathways for accessing HIV-related clinical services. Malaysia is a multi-language nation. Participants identified having an Ai chatbot that can communicate in multiple languages was critical to achieving health equity in Malaysia. Also, we found that MSM prefers the Ai chatbot to be embedded in an MSM-friendly NGO or clinic website. Participants believed that these platforms may offer greater privacy and a more secure virtual environment than our social networking apps such as Facebook, Twitter, or Instagram, where users are required to register using their personal information. Based on the findings from the focus group interviews, we worked with chatbot developers to create the chatbot version 1.0. Specifically, we first create a baseline script using the decision tree model. In this model, each root node represents a question sent to participants by the Ai chatbot, and each decision node represents an answer provided by participants. Leaf nodes are action plans provided by the chatbot. Those questions and action plans are targeted, tailored, and personalized specifically for MSM. Along with the HIV care continuum and based on information, motivation, and behavioral skills model of HIV prevention. The script was reviewed and modified by our community advisory board, which includes MSM representatives, clinicians, and experts from non-profit organization in Kuala Lumpur. Next, our chatbot developers incorporate the script into the code and created an algorithm based on the script. After creating the version 1.0 of the chatbot, we conducted 2 waves of alpha tests, which are internal usability tests among 8 researchers and 7 community advisory board members who are experts of HIV care in Malaysia. Later, we delivered written feedback to the chatbot developers to update the version 1.0 to version 2.0. After the alpha testing, we conducted beta testing among 14 MSM. The figure on the right side of the slide is our flowchart of the beta test. Every beta test had 3 steps, including our 45-minute chatbot human interaction session, our 35-minute follow-up interview, and our 10-minute online survey. In the chatbot human interaction session, we used the think aloud method to observe our participants' interaction with the chatbot. Specifically, the participant joined our Zoom meeting, shared his screen, and interacted with the chatbot to complete 3 to 5 tasks that he randomly selected. Some of the tasks include ordering an HIV self-testing kit, finding a nearby clinic that can provide HIV testing service or PrEP. While the participants was interacting with the chatbot, he was asked to speak out his random thoughts and impression of the chatbot. We observed the process and documented key findings and questions. After the chatbot human interaction session, we conducted our semi-structured interview to further explore participants' feedback on the chatbot. Finally, we sent participants an online survey to assess the acceptability, practicality, demand, and adoption of the chatbot among MSM. Right now, our team haven't finished analyzing the data yet, but we have some preliminary data from the online survey. We found that 93% of the beta testers highly rated the quality of the chatbot. All of them perceived the chatbot as a helpful tool, and their satisfaction score of the chatbot was high. All participants indicated that the chatbot was easy to use. On the developer's platform, we documented about over 2,200 messages, but only 64% of them agreed that their interaction with the chatbot felt like human natural conversation. So we will continue to improve the chatbot. And what we're going to do next is we're going to continue connecting feedback and updating the chatbot specifically through a national observational study. And what we're going to do is we're going to embed the chatbot prototype into 2 websites and conduct the study among MSM in Malaysia. Here I'm going to do a quick demonstration of a prototype of the chatbot. We named the chatbot Haris. It's a Malaysian name, and the chatbot interacted with the participants by introduce itself and provide 3 options for participants to choose. Participants can type their information in the chat window, or they can select any of the options. These participants select HIV testing, and the chatbot asked, "What would you like to know?" And the chatbot, the user select get an HIV test. And then the chatbot tell the participant that there are 2 ways you can get tested. One is test at the clinic, another one is test at home. For example, if this user select a test at the clinic, the chatbot will ask the user to enter the city, the nearest city you are located. And these participants entered Kanja, which is a city located in Malaysia. And then the chatbot provided some clinics in Kanja, which can offer HIV testing services. And the chatbot asked whether you wanted me to email your clinic list. If the participant selected yes, he needs to type the email address, and then the chatbot will document the email address, and the woman will automatically send a list of the clinics located in Kanja, which can provide HIV testing services to the participant's email address. And then the chatbot asks, "What else can I help you?" And then the conversation can continue. This is a very brief demonstration of the prototype of the chatbot. And currently, we have already developed the chatbot prototype into our website called My HIV 365. This is a website that we created specifically used for delivering the latest information about HIV prevention, treatment, and testing to the MSM community. So the above information is about the first 2-year exploratory phase. And after the first phase, we're going to enter the second phase, which is our R33 project. We will use the findings from the R21 phase to inform the our type 1 hybrid implementation science trial to evaluate the efficacy and implementation outcomes of the Ai Chatbot for HIV testing relative to treatment as usual. We plan to recruit 296 MSM in Malaysia. The study will last 180 days for each participant. The primary efficacy outcome will be HIV testing over 6 months, measured as proportion of participants tested for HIV. And implementation outcomes will be assessed using the multi-level RE-AIM framework to study participants' perspectives of the relative advantage of Ai Chatbot over treatment as usual. So the goal of the R33 phase is to test the efficacy of the Ai Chatbot and the implementation outcomes. In the R33 phase, we will continue to update the script of the chatbot using the feedback connected from the R33 phase, including the national observational study. The updating work will also be based on the decision tree model and information motivation behavioral scale model. After updating the script, our AI engineer will incorporate the updated script into code using Python and Prolog programming languages to create an algorithm that can generate a library of text messages. Later, the AI engineer will incorporate machine learning into the algorithm to enable it to generate automated new messages. We are funded by the National Institutes of Health. Here are the 2 QR codes which you can scan to learn more about our studies. This chatbot project has made great progress during the past 2 years, and we acknowledge the contributions from our collaborators and partners located in the US and Malaysia. And that's a project. Thank you very much for your attention. We're looking forward to the discussion and a QA session.
Thank you so much, Zhao and Jeff. Really interesting work. So we now fortunately have a little bit over 20 minutes for discussion. I'm going to invite Dr. Marek Jaworski to initiate the discussion, and then we'll have an opportunity for open questions for the panelists. Please, I see some questions that are already coming into the chat. I appreciate those, and we'll get to those in a little bit. So with that, I'll turn it over to Marek.
Thank you for this very interesting presentation, and I'm happy to see that you made substantial progress in your studies. It's obviously still in the preliminary phases, but it looks like you're making good progress. This type of work on these types of applications of new technology are very much needed in not only Malaysia, many places, and there are many barriers, and access to HIV testing and care is still minimal or restricted. Like you presented some data, and we know that majority of people who should be tested and should receive these interventions do not participate in, do not contact even with healthcare providers in Malaysia. So anyway, we can improve that. It's would be very welcome and will lead to great progress. So thank you for that work. I've seen that audience is eager to ask you questions, so heading and
Great. So we've got quite a few questions already. And I think what I'll try to do is maybe kind of find some similar themes and ask you to respond. So we've got a number of questions related to concerns about the perceptions of users of what they were interacting with. So just an example of that was Loretta Grau is asking, what did you learn from the participants about how they thought a chatbot could be perceived as more humans? And Deanne Turner has a good question about whether when the chatbot is embedded in the website, are participants told that they're communicating with a chatbot versus a person, or is it just assumed based on the structure that they'll be able to select options? And really, she's interested if participants would know that they'd be able to reach a person initially or at some point in the chat. So we just talk a little bit about that issue of humanity versus chat robot interactions.
Zhao, do you want to take that one?
Yes, thank you, Jeff. So in terms of the question about this chatbot embedded into the website, whether it's going to be a person or it's going to be a chatbot. I mean, as a user, our design right now is you will know that is it's a chatbot. Previously, we used the icon of a person, and some of the testers from our beta testing told us that they prefer this to be a chatbot, so then they feel secure and their privacy is protected, make them feel in that way. So that's why we changed the icon to our chatbot. So the chatbot we're creating, it's a chatbot. It's not a person, and it will be able to eventually be able to link to healthcare professionals if sometimes the chatbot is not able to answer some particular questions, or when the users wants to connect to the healthcare professionals, and then we will have a real agent be able to be connected to the chatbot. Yeah, I hope that answers the question.
Are there specific features of the way the robot or the chatbot interacts that kind of are perceived as more human in terms of the language they use or the voice quality? I'm not sure if voice quality is a feature of the chatbot as you described it.
Yeah, so right now it's not among the features, but eventually it could be embedded into the chatbot. And how to make the conversation be natural, that's our major challenge for developing our chatbot, because we need to improve the algorithms and to conduct an iterative process of testing the chatbot to make the conversation be natural. And yes, through the alpha and beta testing, we have already improved a lot on that part of the chatbot, and we will continue to connect in the data. So a national observational study, we will be able to observe what type of conversations the users they entered, and what type of questions were not able to be answered by the chatbot. Then we know how to train the chatbot in the later phase.
And if I could add one thing to what Zhao said.
Yes, please.
To make it more Malaysian and make it more human-like, our participants also suggested that we add some utterances that are very common in Malaysian everyday language. For example, in the US, can you give me your digits? Can you, what's the 411 on that, right? So these little, in Malaysia, they said, can you make the chatbot say la, L-A-H, which is a very common thing to add at the end of a sentence, Oh yeah, no problem, la. If you add that, it makes it look and feel more Malaysian. Or boleh meaning, yeah, I can, no problem. So adding those little things would make it look and feel not only more human, but more Malaysian.
Yeah.
Next, there's a whole series of questions kind of related to cybersecurity, and you talked a little bit about that, but just as a flavor for some of what's being asked, is it possible for the chatbot to be hacked? What kind of IRB or security issues did you encounter when you presented the project to IRB? And also questions about how your community advisory board responded to some of your plans in terms of cybersecurity. Could you just talk about some of those issues?
Yeah, I can go first. I think in terms of, that's a good question in terms of the security issue. That's a big concern relevant to many mHealth interventions. And in our project, what we're going to do is, in the beginning, actually, we were planning to create the AI chatbot and embed into our social networking app. And because social networking apps are widely used in Malaysia among MSM. But after the focus group interviews and alpha test, we realized that that's a more practical way to do in this phase is to embed into our website, which created by our developer, which means that the data will not be able to access by other companies. And so that the participants can feel comfortable of interacting with the chatbot and providing relevant feedback. And so in terms of specific things, what we did is first we embed this chatbot in the website that we created called My HIV 365. The website is under control of our developer and who understands how to protect the participants' privacy. And the second is we try to connect less personal information. When we tested the chatbot, like in the later phase, we're going to conduct the national observational study. We're not going to ask about your names or even your phone numbers. Basically, the users, they just randomly interact with the chatbot, providing relevant information, and then give us feedback. And then we can use the feedback to improve the chatbot. We're not going to identify the participant based on their information. But on the developer platform, the chatbot developer will be able to identify the IP, but we will, that's relevant to IRB. We will make sure those IP will be protected, not be distributed publicly.
And if I could also add that Jamie mentioned about the CAB. How did the CAB, if they identified any concerns around privacy and government surveillance? Yes, and one of the things that we did was, in response to their concerns, is we made sure that the server that we host this chatbot on is not in Malaysia. It's a foreign server. I think it's in Singapore. And we also used Microsoft Azure as one of the sort of gold standards of data security. So it's not sitting on a server in somebody's house or in an office somewhere. It's cloud based. And the CAB was actually very mindful about, balancing the benefits of disclosing information online and the benefits that that could bring, while also, minimizing risk by taking such actions as not requiring them to create an account, not requiring them to disclose personal information in order to benefit from the services that the chatbot provides.
Thanks. That's a very thoughtful approach. I guess another common issue that comes up when you think about digital health interventions, and I think you guys mentioned this in your talk as well, is just the concept of health equity, digital literacy, reading and writing. Could you talk a little bit about how you encountered that? I believe you mentioned that you're using several languages, but if you could just say which languages you're working with now and how you dealt with that kind of broader issue, or how you're thinking of evaluating it in your trial.
Yeah, Jeff, I can.
It's a really good question. Go. Yeah. Yes, please, Zhao. Yes.
Okay. Yeah. Thank you. Right now, in current stage, we only used English because our developers they were from the US and from Thailand, and some of them were from Taiwan. They were not from the Malaysia, so they will not be able to speak Bahasa Malaysia. And also we cannot speak Bahasa Malaysia. So that's why we used English to first create the prototype, and then test the usability and acceptability of the chatbot. And then in the later phase, what we plan to do is we plan to also have a version of the chatbot which is in Bahasa Malaysia, because that's the official language in Malaysia. Almost everybody can understand. And the reason we do that is because among the alpha testing and beta testing, we received, especially the beta testing, we received a lot of feedback regarding English language, and users, they prefer, some of them, they cannot speak English. They prefer to use Bahasa Malaysia as their native language to interact with the chatbot. They feel more comfortable. And so as more tests we conducted, we realized that is an important point we need to address. But the process of developing the AI chatbot, we cannot do like in two languages. Our step is to first create English version, test its usability and acceptability. And then we work with the developers to translate the English version into the Bahasa Malaysia version. And then we continue to train this chatbot use Bahasa Malaysia.
And that's an uphill push from what our engineers tell us is as I mentioned in the beginning of the talk, that the AI component of the chatbot is only as good as the data that it sits on, much like Siri and Alexa sit on enormous troves of data that are able to predict what the intent of the user is. We are starting from, the ground up in building this, especially in Bahasa Malaysia, as Zhao mentioned.
You've already kind of mentioned this a little bit, but I wonder if you could talk, just sort of advising others in the group who might be interested. I know there's a few that are interested in using chatbots for other types of issues in HIV/AIDS, and perhaps even for PrEP and HIV testing in other countries. Tell us a little bit about your advice and what you think are the key team members to put together a proposal on a project like this. And especially what are your learnings over the last 2 years?
Jeff, you want to go first?
Sure, Zhao. We learned a lot about what to do and not to do. Finding and recruiting the right software, computer science, engineer experts is really critical. And that we found is not easy at all. In fact, we've gone through more than one or two such individuals, and each one of them bring a unique special skill to the table, but they don't all code in the same language. They don't all have the HIV background. They don't work in Malaysia. So that's been a real, probably, Zhao, I don't know if you agree, but one of the biggest challenges that we've had is bringing in and retaining these very specially skilled individuals to do this work. And it is not a one-time, coding gig. It is a endless stream of training, retraining, recoding this software. And I mean, not only Zhao in particular has taken the mantle on, learning a lot of the coding himself, which has been remarkable. But I would say that that process of finding those right experts is crucial, and has been our biggest challenge, I think, to date. Zhao?
Indeed, I totally agree. I think to develop a chatbot, you need to have a good team, which includes scientists, researchers, and also developers. Jeff mentioned about the developer. The developers are very important because the AI chatbot is different from prescripted chatbots. And AI chatbot is a new concept, even in the industry, in the AI industry. And how to define an AI chatbot and how to create the algorithm itself it's a challenge. It's a new thing. So that's why it's very challenging for us to find our suitable developers who is able to do this. But we have already made a lot of progress on that part. And the second part, I think Jeff kind of briefly mentioned about is the AI chatbot needs to be trained. You cannot create a chatbot just in a short period of time. You need to constantly train your chatbot based on the feedback from real users. So that process it's an iterative process which requires a lot of time and energy from the researchers and from the developers' close collaboration. What we are doing right now is constantly testing this chatbot, gather feedback, and then deliver to the developers, and then the developers update the chatbot. And then we tested the chatbot to see whether it's being updated and which part needs to put more efforts on. So it's a continuous process. And so those were the two challenges, I think.
So one more question, and then I think what we might do is just invite any of the participants to raise hands. There were a lot of questions, but I may not have covered all of them. And so if people want to follow up, please feel free to be recognized. So my question really is, as you're thinking about doing this trial, when you introduce new sets of technologies, it's very powerful in terms of being able to recruit people, I would assume, from anywhere in Malaysia. But when you think about comparing that and the control arm, how are you guys approaching that challenge in terms of making sure that you're measuring your outcomes in similar ways in the two different groups? I'd love to hear about that because it's something that I think many of us struggle with in this area.
And Jeff, I'm going to go first, if you don't mind. I think that's a very, very good question regarding the R33 phase. So what we plan to do is there are two options. One is we compare the AI chatbot group with treatment as usual group. Basically, we can use give some manually mHealth intervention to the control group. And another option is to create an attention chatbot, which is a prescripted chatbot. And so we have two groups. The experimental group receive interventions from the AI chatbot. The control group receive interventions from the attention chatbot, which is not an AI chatbot. And then we can compare the two.
That's fascinating. It'll be interesting to hear more as you guys go along. We'll definitely have to invite you back.
Thank you very much.
So are there any other questions that anybody want to raise their hand and be recognized? I think just a lot of kind of positive questions coming in. So I guess there was a couple questions just in terms of how the chatbot interfaces in terms of scheduling and some of those items. Jeff, you were kind of responding to Jamel on that point.
Yeah, that the option to schedule a test or a clinic appointment isn't yet available, but we do have the option to order HIV self-testing kits. I'm not sure if we got into that in the talk. I don't think we did extensively, but an ordering feature has been embedded in the chatbot. You don't have to leave the chatbot to place the order. You can place it right there in the chatbot, and it will be delivered to the user to their door or whichever location they request it. The option to schedule appointments is a future feature that actually one of our most recent engineers recommended, but that would probably require linking to a booking website outside of the chatbot at this time. The chatbot doesn't quite have the ability to schedule it, and part of that limitation is many clinics don't do online scheduling. COVID has catalyzed a lot of government clinics in Malaysia towards using online booking systems, both in the government, private sector. So we have seen an increase in that. And some of our clinics do have a link. So when you in the chatbot and you give me a clinic in, say, Penang, it will say, okay, here are the clinics in Penang. And if it does have an online booking option, that link will be available to the user in the chatbot. But the chatbot can't actually do the booking yet. Certainly we're dreaming in that direction.
Yes.
Well, thank you so much. This has been tremendously interesting. I definitely also want to thank the audience members for raising so many good and insightful questions. Obviously, Jeff and Zhao have developed a great expertise in this area, and I'm sure they'd be open to answering any questions if you are also considering similar digital health interventions. And we're hoping to build that type of expertise here at CIRA, and we do have a number of researchers who are developing a lot of expertise, including Zhao and Jeff. So thanks also to Merrick for your role in moderating, and to Dinny and Pete for organizing this great session. I think Dinny talked a little bit earlier about some of the upcoming events that we have. Those are available to you also in the chat through the flyers that are there. And with that, I guess we'll say thank you. Anything else you'd like to add, Dinny?
That's all. Thank you, Luke. Thank you, Jeff, Zhao, and Marek. I just reposted the file with PDF and links to the upcoming events. Thank you, everyone, for participating.
Thank you very much for your attention.
Good luck. Have a good day.
Thank you.
Thanks, everybody.
Bye.